This is an example of how you give SBAR report. Situation, background, assessment, and recommendations. Good morning. Do you have
Hi.
patient 224?
I actually do.
Okay, I have a report for you.
Okay, all right. let's
Okay,
hear it.
so it's patient 224, bed 2, initials TK, age 74, male. He was admitted on the 9th, full code. He was admitted for sepsis and pancytopenia. He's not in isolation. Cardiac diet. He's allergic to acetaminophen and hydrocodone. Currently, right now, he's on bed rest. Fall precautions are implemented and the bed alarm is on. The patient was admitted to the ER due to suspicion of sepsis. He had complaints of sudden bilateral decrease in extremity weakness resulting in a fall. CT negative for stroke. Temperature was 102.1. Cultures were drawn and the results are pending. So antibiotics are started, and I already started him on his first dose of Zosyn.
All right.
Okay, so the shift priorities are monitoring for the development of sepsis, monitor oxygenation breathing, cooling measures, and IV fluids. His background, he has a health history of COPD, CHF, GI bleed, diabetes mellitus, borderline, and hypertension. Looking at his diagnostic test, we're worried about his white blood cell count. It's 3.2. His H&H are also low, hemoglobin of 9.5 and hematocrit of 27.5. His platelet counts are also low at 60. His PT, INR, and PTT are high. We're also worried about his potassium. It's slightly low, it's 3.4. His BUN and creatinine are also high. So we're just gonna watch out for his white blood count because 3.2. His bone biopsy was done, it's pending, and a blood culture is also pending.
Okay.
During my during my shift assessment, he was ANO times 4. His heart rate was high. At 1300, it was 101, but he denies chest pain. His respiratory, there was crackles in the anterior and posterior lobes. He has some deep labored rapid breathing, dyspnea, and he's also on 2 liters of oxygen and saturating between 88 and 91%. His GI is unremarkable. His last BM was on the 9th, and his GU, musculoskeletal, and skin are unremarkable. He was a little agitated in the morning. He's a little anxious towards the end of my shift, and he has a history of diabetes mellitus, but no AccuChecks were done.
Okay.
His vital signs were a little unstable. His respiratory rate was increasing throughout the shift. At 1300, his respiratory was 24, and he spiked a temp of 103.5, so cooling measures are being implemented. We put some towels over his neck and forehead. His INO is adequate. He has an IV right antecubital, normal saline going at 75 milliliters an hour, and he has 2 different channels, channel A with normal saline and channel B with a primary line of normal saline with Zosyn at 13.8 milliliters an hour. His shift priorities again are oxygenation, breathing. He does have, the RT came in and did a breathing treatment with him, albuterol, 2 puffs, PRN. Again, he's on 2 liters of oxygen. He didn't respond well to it. He still is having dyspnea and labored breathing, and his pulse ox is still around 92%. So the new orders for the shift is to transfer him to critical care unit due to the worsening of labored breathing. He needs patient education about the disease process, signs to look out for, also about his treatment and medications. There's no current discharge plans, but if the patient does get discharged, he will be returning home with his wife. So resolution of his signs and symptoms of sepsis would be a great indicator that the patient's improving and would be able to go home. The priority nursing diagnosis are impaired gas exchange, risk for shock, and ineffective protection.
Awesome. Thank you very much.
Good luck, and remember, communication is key.